Good evening. My name is Rick Thomas. I am the Vice Mayor of the City of Willows, and it's my honor to call this special joint meeting on Monday, June 1st, 5:30 at the Glenn County Board of Supervisors and the City Councils for both Orland and Willow. So we all stand and salute our flag. Thank you. I enjoy a good, robust pledge.
Yeah, that
Thank
sounds
you.
good.
Let's do a roll call, starting with the Board of Supervisors.
Supervisor Errant,
Present.
Supervisor Rossman,
Present.
Supervisor Withrow,
Here.
Supervisor Yoder,
Here.
Supervisor Carmen.
Present.
And for the City of Orland,
Mayor Barr, Vice Mayor Enriquez,
Here.
Councilmember Toll,
Here.
Councilmember McDermott,
Here.
Councilmember Elliott,
and for the City of Willows,
Mayor Hudson, Vice Mayor Thomas,
yes.
Councilmember Busby, Councilmember Pride, Councilmember Hanson.
Here.
Okay, item number 3, public participation. Members of the public will be allowed to address one of the items listed on the agenda. The law requires a business not appearing on the agenda may not be discussed at a special meeting. So I think with the intent of this crowd and this participation, we'll call for public participation now if you'd like to speak. And after the presentation, we'll give the public another opportunity. That's okay with the group. So with that, we're going to move straight into item 4, presentations of Glenn County Emergency Medical Services System Assessment. Chief Nate Bunk, Chief Justin Cheney, and Dr. Jared Garrison. Let's start.
Good evening, councils and Board of Supervisors. Just real quick before to introduce the consultants, we have 2 consultants tonight from Healthcare Strategist Solutions. It's Bill Bullard and Lou Meyer. They're the 2 main consultants that worked on this project. Just to remind everybody in the room a little bit of the history, this study was a joint funded endeavor for the 2 cities and the county to work together to find an outside third-party fresh perspective to look at our EMS system, see where the strengths of the system were, where some of our weaknesses were, if there was some low-hanging fruit that we could find to clean up efficiency. And so when Glenn Medical Center closed, we knew that that would have a major impact on our area, and that was kind of the catalyst that spurred this on. And with that, that's kind of my pieces and parts, and I'll pass it over to Dr. Garrison to say anything he'd like to.
Yeah, I don't think I have much more to add. Yeah, we're just trying to find out the best routes possible.
I think Chief Monk said it all, so I think presentation time.
Yes.
I think that's your cue.
Bullard. Back.
Can you talk more into your microphone? It's not.
There we go. Is that better? Am I now,
Yes.
am I hitting the
Yes.
people at home? I apologize. My bad. Okay, next slide, please. So some of the highlights, it's a coordinated system. We have good leadership from the Sierra Sacramento EMS agency, and that always helps. We had broad stakeholder network spanning dispatch, first response, ambulance transport, receiving facilities are working. Thank you. And you have access to a dispatch center that does what we call MPDS, or Medical Priority Dispatch Services. That's more simplified in the fact of pre-arrival instructions. So CPR, the choking, bleeding control, things like that, which not all centers, if you can believe it, do that throughout the state still. Those calls start off with the primary dispatch center and then end up there if it's medical. We also have the EMS direction aligns well with the state and nationwide as far as EMS agenda for 2050, which is our kind of our Bible looking forward to how we ensure that we're doing the most for our patients. Next slide. So the areas that we would recommend seeing some work perform is the clinical oversight and the continuous quality improvement, really focused around making sure that all providers are providing what's patient-centered care. We don't want to get there quickly and then not necessarily be doing the things that matter the most for the outcome of the patients. So everything we need to be doing needs to be focused on that clinical oversight and ensuring we're doing it the best we can. Currently, the ambulance response times, as we look at those, are below the standards set in the contracts. That's very typical, especially post-COVID, with all the challenges with hiring paramedics and providing coverage. And as we look in communities that have larger expanses of land to cover and not necessarily a large population, the call volume, the number of transports, doesn't fund the level of coverage you're looking for. We just did a similar study in Tuolumne County that has the exact same challenge. More land than they have transports to provide revenue to provide the coverage. What we need to look at is setting realistic performance expectations. Based on where people live, if you live in this downtown urban center where the ambulance is stationed, your response times are probably fairly good. But if we choose to live on the rural areas up in the mountains, in the fringes of a county, we're probably not going to see the same response times, and we need to set that expectation with our customers who are residents and our visitors. It's also important that we look at the fact that response times are not the end all and be all we once thought they were. We all thought it was get there quickly, it's easy to measure, and that's going to make a difference. Well, what we've learned is it's actually more about the care we provide when we get there and the care that's provided before we get there than the actual response times. 1, 2, or 3 minute difference isn't providing the clinical difference that we once thought. Talking about the fragmented data limits, data was a bit of a challenge with this project. We'd really like to have that all going to one place, so that could be the patient care reports going to one place. There is one data center for dispatch, which is great. Another challenge in the current system is longer transport times. Now with the county hospital closed, that means that every ambulance run is going to take longer to complete and more time to get back in service for the next call. Financial sustainability, that's why we're here tonight, that's why we're talking about this, is that the risks of that, of having enough coverage and patient revenue, and then having to add some subsidy to that to make the coverage to the level that you want it to be at. And what we want to see, especially when subsidies are involved, is we want to see each provider required to provide audited financials so that you, the stewards of taxpayer money, can feel comfortable that what you're being presented is a realistic picture of what it costs to provide the service. Next slide. All right, so now we'll get into the more of the nitty gritty, if you will. So this is based on our experience. I've been in the business about 40 years now. My partner to my right, Lou Meyer, has been doing this for over 50 years. He has owned an ambulance company in Stockton and also was a major vice president of a national corporation and covered a lot of California with that process. The recommendations we're coming forward with, some of them may require the system to go out to bid. An EOA on here is called an exclusive operating area. And when a system goes out to bid, it gets then that exclusive status, which means that I can't buy an ambulance and decide to compete with whoever wins the contract. What we recommend is what's the ideal system. This room is entrusted with figuring out how to make that work through the financial resources available and any other type of provider interest in providing that. If we have no providers interested in the service and the system we design, then that's an influence we have to work through. On the slides, there you see the findings and recommendations in red. Those are the ones to pay the most attention to. That's what the biggest takeaways are. If you would, thank you. So we talked about this in the overview, so I'll glance over this quickly. We have the use of MPDS, and that's what's providing those pre-arrival instructions. That's what's making sure that people get care before first responders and the ambulance can get there. We want to make sure that it's happening today, and that should be formalized to make sure it happens into the future. And that's, as of January of 2027, will be something that's mandatory through a state legislation. We also like to suggest what's called ACE accreditation. That's for dispatch centers. That is their gold standard for saying we're doing a good job. Please. I waited till you got that far away. Sorry. Okay, clinical oversight and performance. As I mentioned, we used to think 40 years ago it was all about getting there quickly and that was going to save lives. What we realized is we need to get there, but we need to provide those instructions ahead of time to sustain someone while we're getting the responders en route. Once that's done, we get on scene. It's our job to provide the highest level of care possible. And that's where we're looking at things like if it's a trauma patient or if it's somebody's having a heart attack or a stroke, we don't want to sit on scene with them for a long period of time. We want to get there, pick them up, and get them to the hospital, because really the hospital is going to be the one that makes the biggest difference in those type of situations. What we found while here was that the clinical oversight is fairly inconsistent. You have two providers, which you have two different ways of doing it. And where you want to see a better performance and quality improvement processes across all the services being delivered. There is a regional quality forum called REMAC, which is the opportunity to do that. There was a concern brought up that some of the responses to some forums, MCI feedback forum was one that was brought up, isn't as consistent as it needs to be. And as I mentioned, that's I skipped to the recommendations first, so I kind of did that in reverse and keep going. Deployment of ambulances. So today, there are 2 ambulances on duty at all time and a third ambulance on duty half the time, so 12 hours a day. The prolonged ambulance response times, and we'll see that in the compliance data on the next page, essentially is something that then creates delays in the system overall. And in most systems, we have is called system status management, which means the dispatcher is moving the pieces around the board to ensure that if you have 3 ambulances, they're equidistant, so to get the best response times. And then if one gets deployed out, then the 2 that are left, they move to provide the next level of equidistant care. And then if those 2 are both committed, then you have the third one that is closest to where the next call is going to, like percentage-wise, is going to happen. So that's what system status management is, and that's what we want to see in a system. And it can be done with 1 or 2 or any number of providers, but having the single dispatch center is where it gets coordinated the best. The other part of that is by having that, we get the closest unit responding. So there may be a situation where ambulance A is closer to ambulance B, even though ambulance B might be the one that normally runs there, but they're coming back from Glenn County, or they're coming back, excuse me, from Enloe, and they're driving right by the call. Those type of exceptions need to be allowed because it's not about who gets the call, it's about getting the patient the help as soon as we can. And that's covering, so the move up in coverage plan that's in that system status we're talking about. And then monitor dispatch to en route. We did look at some of the data and want to make sure that we have, when the ambulance gets the call, when that crew gets it, that they're responding in a timely manner. Typically, it's about 60 seconds that we're looking for. That sometimes will extend to 90 seconds at nighttime, realizing people need to actually sleep and take their boots off and back on when there's a call. Finishing that up would be then the continuous quality improvement or CQI review, corrective action for making sure that that is happening on a routine basis. Next slide, please. So here's looking at the response time compliance. Simply, the top line is Orland and West Side. The lower or middle is Willows and Enloe, and then county is overall when it's all put together in the hopper, if you will. And you'll notice that Willows had more months that it was out of compliance than the Orland area. Primarily, it looks like the 12-hour unit may not have been deployed as effectively and efficiently as we talked about on the prior slide to ensure that that coverage is happening quickly. And that's what we want to look at. The description we heard is that the 12-hour car and the 24 did more of a rotation to balance the workload between the two units. And that's really not the focus of it. The focus is to have that unit, have all three units being as efficient as possible, not necessarily giving one crew more of a break than another. All right, next slide, please. This is a little hard to see. I apologize, but it's in the slides and I'm sure those were produced as well online. We looked at call volume, number of responses, and the number of transports going across the last few years. And specifically, those that are more of a hash mark, like a barber pole, those are the since Glenn County Medical Center closed. And essentially what you're looking at there is how did it change? There's a lot of conjecture, a lot of assumptions that the call volume was going to go down because there are no more trips from Glenn County Medical Center to Enloe or another facility. And so because of that, there was that assumption. Well, what we've seen is it's dropped a little bit, but it's fairly negligible. The 911 volume has come up as that hospital is no longer an option for the community. And so that's what we're seeing here. The response and transports are, like I said, are about even, maybe a couple points down, but not enough within, I guess we're almost 9 months now to say it's statistically significant, but it is definitely something, and our recommendation is we need to watch that. We need to be keeping an eye on the fewer transports there are, the more of a revenue challenge we have to keep those units subsidized. All right, next slide, please. So here's the financial history of the two services, West Side and Enloe. You can see 23, 24, and 25, which are the years that have ended. Bottom line, neither service is breaking even. So as two independent companies with two independent expense sides, they're not able to break even. And so this is where we're getting into the subsidies that are requested today. There are other EMS system designs that are more efficient from a financial point of view, and we're going to talk about those next. Here's just a review of Enloe. We looked at their financials for 3 years, their payer mix. This is all contained in the report and the appendices if you'd like to look at them. They were solid, professionally produced, specific to the service. It wasn't the whole Enloe hospital or health system. And we found them easy to read and exactly what we would expect. We would continue with any type of subsidy requirement that become a part of the contract between the county, cities, whoever, and the Enloe as the provider. Because that's what you need to do to be able to look at your residents and say it's a cost-effective use of their money. Next slide starts looking at the West Side. And you can see we've got some it's hard to see the West Side's financial comparison, but we've got a couple years up there. As I mentioned, we had, I believe, 3 different sets of financials. The last ones were the ones we worked with. We noticed there were some, I should say our fiscal expert noticed there were some revenue items that didn't match up in the summary reports. Usually the cost of goods sold is in a different section, and that's how in the deductibles for Medicaid and Medi-Cal, how they work in there, and how that works is usually held in a different way than the financials we received. So that would be an area that we would recommend correcting in future drafts. There is not a requirement right now for West Side to produce audited financials as a service that's being subsidized. That is something that you should get, and I think I won't belabor that point anymore. All right, please. This is a laundry list of just little things as far as QuickBooks, which is what they use, has a lot of people working in there, which it's got reconciliation issues, reporting issues, and some other areas in here that would be it for West Side to continue. About 6 things in there that would need to get shored up to provide a better, cleaner, more formal reporting to you as the council and the county. Next, please. All right. So in this slide, what you're looking at is the comparison of Enloe and West Side's performance from a financial point of view. And so right now, this is for 25. West Side is looking at about 1,200 callers, and Enloe is about 800 change. You can see what the revenue is. You can see what the expenses are, and then the revenue less expenses and what that looks like. And then we combine them to show you what it looks like overall. And this is without the subsidy. So you're looking at the raw data, if you will. And so you're seeing it's about $500,000 upside down. There is per trip applied here. So you can see where one service is providing more or less efficient, depending on where they're buying things from, where they're getting insurance from, where they're buying their supplies, things like that. The supplies is an excellent example of where Enloe has the buying power of a major health system. And so they then are able to then keep their costs down in that area. And there has been an offer from Enloe to West Side that if you want to buy your supplies through us, you can do that. And we've seen that even from big players like the American Medical Responses, things like that. They'll let their fire departments buy supplies through them because then they have more buying power because they have a bigger bucket to negotiate when they want to renegotiate their rates. Okay, next slide. So this is the first slide where we start looking at different system designs. So we have the current providers, so the 2 providers in the first column, and that's where it's about 480 some odd thousand in loss right now. And then we said, okay, if we took the 2 providers and made them 1 provider, what would that look like? What would it look like from a overhead point of view, from insurance, things like that? And you can see that we can knock out roughly about, to get closer to my numbers here, almost $200,000 in cost, in expenses, by creating that efficiency and having 1 leadership team, 1 insurance company, and along those lines. And you can see where we've made those changes. There's not a deduction in crew wages. There's not a deduction in benefits for the employees. This is truly from an admin and above point of view. The third column is what's called our public provider. And for those familiar with it, there are additional payments available, higher rates for public providers and private providers. The short answer to this is it ties back to a federal law that says that a patient who's the responsibility of the government, of the federal government, cannot be costing the provider money. Can't be doing it for below cost. This started in the hospitals, critical access in those areas where in any public healthcare district hospital, And so then they would say, okay, well, we're going to pay you more because we know that Medi-Cal is below cost. That about 15 years ago got moved from the hospital environment to the pre-hospital environment. And that changed dramatically. Just to give you perspective, a typical Medi-Cal patient is about $150 transporting, more or less, depending on mileage and other things like that, nighttime, oxygen. In Tuolumne County, they're just under $1,500 for that same patient for cost recovery. So it's almost a 10-fold increase in payments for Medi-Cal. A lot of systems, and it's in the report here, I apologize, I don't remember the off the top of my head. The payer mix is there, and you can see how many of those patients are Medi-Cal. So, and I'm going to talk a little bit more about some changes that came up literally within the last 2 weeks to go over that. So that, by using that money to put into the system, we can actually take those Medi-Cal from a below cost and move them into a above cost or at cost basis that then rises up and actually flips it from a subsidized system to a non-subsidized system. And before you get too excited about not having to make these payments anymore, unfortunately, I'm going to burst your bubble here when we get to the questions and answers, because unfortunately, we have some latest developments out of Washington at the top. So at a minimum, 2 providers versus 1 provider, it's going to be more expensive with 2 providers today than having a single provider and removing some of those overhead costs. There's an advantage to going to a public system for what we just talked about. Please. Did it change, or did I?
Did it change?
Did it change? Was it different on that slide? Back up one, just to make sure I didn't miss something. So next, thank you. Next step, we took the information we have from 2025, expanded it into a pro forma for fiscal year 26, if this were to happen this year, based on, again, 2 providers, single provider, or a public provider, and what we think that would look like. Because the call volume was down a little bit, you'll notice that the $200,000 number we had there for a public provider in 25 is really more like 130 and change in 2026 due to the call volume going down, but the expenses being roughly the same. Okay, so that was that next step slide. All right, conclusion. So you've got a good workforce. We enjoyed all the EMTs and paramedics that we met with. They're committed to doing it. You've got a dispatch center that's able to provide the type of instructions to sustain somebody until fire and ambulance can get there. So that is the core that you need to then move forward with into what we're going to do next. And that type of dispatch center also gives you the flexibility in the future to do more things, like maybe adding an outside nurse line and referring calls out to people that maybe don't need an ambulance and giving them some other options. And that's where progressive systems are moving. System-wide issues with response time performance, I think everyone knows that's there. We do need to get into the CQI, which does involve labor. We need people to do that. There are some programs out there that will help us to do a better job at ensuring we're doing the best job we can for patient outcomes. Taking the data from multiple providers, getting it into one source, and then getting that contract accountability set up. So our recommendations are 6-fold: move to a single ambulance provider, consider a public provider or alliance model to access what we call GEMT, or that public funding I mentioned a minute ago. Alliance model, for simple terms, is where you, the government, a government entity, is the provider of record, which then gets you access to that funding. And then you purchase unit hours from a private provider. That's currently going on in Contra Costa, Tuolumne, and Sonoma County as examples. Modernized data and CQI infrastructure, we just talked about that. Optimized deployment and tiered response. That's where we make sure we put the ambulances strategically placed throughout the county. Optimized deployment and tiered response. About a third of the calls are basic life support or an EMT level ambulance can handle it. We don't necessarily need to save that paramedic for every call. At least a third of them we know could be handled by a basic life support ambulance. Integrate behavioral health crisis response. This is one of the biggest issues facing us as a country, as a state, as a county, to ensuring that we're providing the best we can and making sure that our ambulance fleet is providing, our staff is providing as best care we can with the best options. The emerging models we're talking about, alternate destinations, community paramedicine, that all starts with having a solid dispatch center that's able to talk to the person, determine whether it's an emergency or not an emergency. And if it's not an emergency, giving them other options. If anyone here is a member of Kaiser Health Plan, you know you have a number you can call 24/7, talk to a nurse who will help you navigate the healthcare system. Imagine if that same thing was provided for every Medi-Cal member, Medicare, Blue Cross, et cetera. And we can actually start to take somebody who's uncomfortable, doesn't know what to do, who called 911 because they're overwhelmed, and to give them better options. And I think that's going to be it for conclusion. Let's see, next steps. So there's two directions to go. Our Tuolumne client, going back up for a second. So the first one's called an exclusive operating area, the EOA. And that's where if a decision was made that you want to have a single provider, you put out a request for proposal and you take bids. You say, this is what we want. We want 2 ambulances or 2.5 ambulances. And what would you charge us for that? And then the bidders would come back and say, here's what we're going to charge. The exclusive operating area, it's a process that gives you protection because the state blesses your RFP and says, okay, this meets our standards, and therefore you can have exclusivity and monopoly for up to 10 years is roughly the going term. And then that prevents another provider from coming in and trying to cherry pick the calls out of the really nice neighborhood or the really busy area of town or something like that. The second area, and this is our second option, this is what our Tuolumne County did, is they went with a non-exclusive operating area. In this situation, the county, with the help of your EMS agency, will go out and you'll put out an RFP and you'll look to see who will come in and do it with you. Without the exclusivity, it's faster to do it. And say if you wanted to have your fire service be the provider, and whether they do it or they subcontract it to a private, those type of things can be done within that non-exclusive arrangement. Because it's a subsidy-based system, there's very little likelihood that somebody from the outside is going to come in and want to buy an ambulance and compete for your 911 calls, because they're going to be doing it for below cost, especially if they can't get all the calls. So those are kind of the two approaches that we see. The most common is the EOA model, the first one on the left, but it may not afford you some of the access to that public funding. And I think the last slide is going to be Q&A here. Yes. All right, so let me start off with just a couple quick things. 2 weeks ago, the federal government came out with a memo that basically said, we are going to change how we do Medicaid and Medi-Cal funding, and we are going to hold it to the allowance of Medicare rates. So where we're at just under 1,500 in many communities, now we're talking about something in the 400s. So that's $1,000 per Medi-Cal transport that is going to go away. This has been threatened for probably about 4 to 5 years. We knew it was coming. Texas went through a massive audit a few months ago. We were thinking it was going to get handled on a state by state basis, and CMS came out with this edict. So by next year, we're going to 27, 28, we're going to see this enacted, which is going to cap it. We think that there'll be political lobbying to continue it longer, to maybe make it more than 100% of Medicare, or phase it in from 200% of Medicare, 300% to 250, to 150, 125, 100, whatever. Something like that will probably happen. Lou and I don't have a crystal ball, but the federal government's hard to fight. You can push them off, you can suspend certain things, but eventually this is going to become a reality. And so our publicly funded systems need to make sure that whatever that system design is, isn't one that's not sustainable long-term. And as we look at the budget and talk about no subsidy needed with the public system, we would still highly recommend that you keep that subsidized amount in your budget and just defer it and defer it and defer it. Because eventually, whether it's 2, 3, or 5 years from now, it's going to come back unless you choose to change the level of service, number of ambulances you want to have in your county. So that's kind of where we're headed. And again, that's not in the report because it just came up. I do have a couple quick questions that got given to us ahead of time, and I thought these would be absolutely great to share with the group. And the first question was, where does the 220,000 come from by going to a single provider? And I think we've talked about that. That's because of that public funding. Or excuse me, to a single provider, the 220, that would be related to the overhead, the administrative costs, things like that. Sorry, single provider, not single public provider. So the question came in about not subsidizing Enlow's ambulance, and what would that look like if we were to stay with a private provider? Would we propose having Enlow be the service for Glenn County? We wouldn't propose one provider over another. What we would recommend is to have a request for proposal process and ask anybody that's interested to bid. And then you choose who you think's the best. Colusa County has a similar model to this where the AMR has that contract and they staff a certain number of ambulances to cover that community. So there are people out there doing this. You have 2 in your county that are doing it right now, and there are ones outside that might be of interest, and that will help you get the sharpest pencil in your bids. Enlow's been operating at a loss, and you can tell they've actually been operating at a bit of a loss even prior to the medical center closing. And if you look in the report in the appendices, it asks about a rough estimate. It's in there, the actual numbers. I don't remember exactly. Hospital-based services are a little different because when siloed and looking just at the ambulance service, yes, by itself for expenses versus revenue, they may be losing money or breaking even. However, remember that they are bringing patients back to the hospital that are being admitted. And so it's a source of bringing in revenue for the hospital. So that kind of grays the situation as far as you see them losing money. They're in the bigger picture, they're doing okay. Question was asked if GEMT goes away, does it make financial sense for take over the losses to become a private county single-wide ambulance service? So great question. This gets down to, even with what's proposed from the federal government, a Medi-Cal transport's $150 today, as we talked about. That's going to go to $450 plus or minus based on mileage and things like that. So a public provider is still going to have a better return, which means that your subsidy would in theory be less. So that's the kind of the yin and the yang of it. How does the 12-hour ambulance impact West Side's finances? It impacts it substantially. I believe it's almost 100% covered by the subsidy that you generate. Don't quote me on that. It's been a couple months since I've looked at the numbers. But that 12-hour ambulance is specifically due to the support that you're providing to it. And so the question is, what if Enlow provided that 12-hour ambulance? It would transfer over, because when the county went from 2 ambulances to 2.5 ambulances, the revenue from transports never changed. It's still the same amount of revenue. It's the same because it's the same number of transports. We're just doing it with more ambulances. So you have better response times, more available ambulances. So Dr. Garrison, did I cover everything okay? Any follow-up?
Just one.
Please.
Currently, we do not subsidize Enlow at all for any of their overhead. And so that was kind of what I wondered if, we're not paying anything for Enlow. we take on Enlow and West Side covering, that still ends up saving $200,000, 220,000?
If the two services became one service with one set of overhead, that's where your savings is. There was no subsidy in those numbers you looked at. So 430 was the number as two separate services, 220 is the number if there was one service. So your subsidy would go from 400,000 to 200,000.
Okay,
Yes.
so we're not taking into the account that we're not for any of Enlow's right now?
Correct. And with that, I'm happy to take questions, or I can sit down and you can
I think
pepper
at
this.
this point in time, I'll call for public comment. Their presentation. Anybody wishing to make a comment? I would just ask that we have so many people here that we try to keep all your comments on point and that we limit duplication previous speaker, so we don't end this meeting into the. Please.
Yes.
Microphone for the staff.
Pardon? The study, was that just ground transport we're talking about?
Correct.
Because Enlow has 2 helicopters. And I would say, having worked at Glenn Medical, that the majority of inter-facility transfers to a higher level of care were done by air ambulance. And the farther reaches of the county, like Elk Creek, would be better served most days, weather permitting, by air ambulance. So whenever you make a decision about are you going to model the provider, please take into account the value of air ambulance.
Could you please state your name for the
Piper?
thank you.
Hi, Michelle Knight. I just had a question for clarification based on what Dr. Garrison had asked. If I understood the information you provided earlier, sir, it appeared, at least to me, that we were paying less for the transports through Enlow than we were the West Side. Is that correct? Because of the overhead maybe differences, or I'm not sure, or the purchasing power that Enlow had. And if that's true, and we only went with one provider, like say through Enlow versus West Side, then would it not be less expensive overall to go through Enlow? I don't have a preference. I know nothing about any of this other than the bottom dollar. And then of course we want the best service possible to our people. But I'm just asking for clarification on that, please.
Sure. So from a revenue point of view, as a patient receiving the service,
Mhm.
it's the same. There's the revenue is the revenue. But because of Enlow's efficiencies, because of their size, they have fewer expenses per trip, which is what you saw in there. The Enlow provides services to other areas like Butte County and other areas up into, say, Paradise and those type, as well as what they do here in Glenn County. And so they're able to spread their administrative costs over a larger area, which is why you see a less cost per transport. The revenue is the revenue. It doesn't change.
But would it not be less expensive for us overall if we went with them as a provider, single provider, rather than West Side?
So this is where we would want to, say we're going to have one provider,
Yes.
we would ask every provider to bid and say, tell us what you would do it for.
Okay.
And then they would come back, and it could be Enlow, could be West Side, could be somebody you don't have today.
Thank you.
I'm like Mr. Piper. When the weather's bad here, I don't know if you took into consideration, they always use the air flight because the roads are flooded and they can't get across the Enlow anyway. So you have to really take that into consideration.
We have a submitted question from Isaiah Rossi. Can you bring in AMR, American Medical Response, or another ambulance company because of response times and not having a hospital in? Anybody that wishes to respond to that? Do you have any?
When we set these up for other counties, we include the use of mutual aid. And so if somebody doesn't have an ambulance available, then what is their plan for mutual aid? And so that could be an AMR, that could be, there are a number of providers around you. And depending on where it is in the county, then that could be the best provider, whether it's AMR or someone else. And that's, one of the factors you look at in the bigger picture when you're evaluating your proposals about who has the best mutual aid and backup services available for your community.
Anyone else?
Steal this chair.
How about from our Board of Supervisors?
I just was looking for some clarification on the GEMT process. You'd mentioned about the public or private. If we were to implement the GMT program and say either one of the fire departments took on the lead role of it, would they then have to provide the ambulance service, or could they contract that out to a private entity and they just were in charge of the billing process?
Correct. So those are both viable options and ones we see in other counties. So Tuolumne County, the public health agency is the provider of record, and then they buy unit hours from, currently it's Manteca District Ambulance, and it's soon to be Mercy Ambulance. Contra Costa County Fire is the provider of record in Contra Costa, and then they buy unit hours from American Medical Response.
When you say by hours, can you explain that a little more? Or do they do like an RFP to?
Correct. So say you just choose to look at that alliance model, that partnership. You would say to your public health agency or to one of your fire services, we want you to go out and do this. And let's say, so today you have two 24-hour units and a 12-hour unit. So that's 60 hours. So you would say, okay, AMR, Manteca, Mercy, Westside, Enloe, whoever, I want to buy 60 unit hours a day from you. What's the bill going to look like? And then you would compare that across all your bids. And we would recommend and that we look at some clinical standards, some other requirements to make sure that you're getting the best care, not just a transport. Does that help?
Yeah, that definitely does. And you'd mentioned about the new federal standards changing. So my understanding, like now before CMS stepped in, they were getting upwards of $1,500, $2,000 for an ambulance ride, but now it's going to go down to
Maybe about 400,
So
450.
it's still substantially over double what it is without using that program, correct?
Correct.
Okay. Thank you.
Yeah, I do. Rick, thank you. Kind of a backstory, because I think we all need to know how we got here. And my CAO, he can correct me if I'm wrong. He usually does. Years ago when we tried to implement this, and this is all through ARPA money, we set aside $750,000. We purchased the ambulance and leased it to Westside. But prior to that, we looked at it, and I know the Chief Monk and Dr. Garrison, because I've asked those questions, is how are we going to, if we put it up into the Orland area, how is that going to transcend and help the South County? And the concept was that once the South County unit deployed somewhere, then the 12-hour ambulance would come down and stage in the Artois area. Therefore, they would have less response times. And so we said that, and we said, okay, we'll do this until we get a proof of concept, basically. And we purchased the ambulance, and we went into the contract with Westside. But that's what kind of got us there. And what really concerns me is that we went to page 11, which is the deployment of ambulance resources. And we look at September 25, November, December, and then February. those areas, if the Willows is at 62% and Orland is at 91, then we got November 75%, Orland 100%, Willows 70% in December to 97, and then 57% to 100% in Orland. That tells me, throws up a red flag, is that we're not doing what we were intended to do. And I think it was added in there is they put them into rotation. They put the 12-hour ambulance, which was not supposed to do that, into the rotation, which now they weren't staging in the Artois area, which was bringing down our response times. And so we're finding ourselves out of compliance. And that's just within, I believe, probably the Willows area. Not to say what goes on in our tribal partners up there and our Elk Creek partners in the county, because that takes even a longer response time. And I think Mr. Piper said, too, is that probably the best way of doing it would be through helicopter. And I think reach through Colusa is there too. Thanks, Garrison, for that nod. But what that throws the red flag up to me, being District 4 and sitting in my responsibility of Willows, is that that does nothing for the South County. It benefits the South County very little. And what that does is that tells me is this ambulance is prioritizing Orland over Willows. That my seniors, my people that need medical aid are less important, to just throw it out there bluntly, and that's my opinion. But if we're looking at 62% to 91%, it tells me is that this contract is not doing what it was intended to do. Willows is not receiving the benefit that it should be receiving based on that 12-hour ambulance and our subsidies to it, because our taxpayers do pay for the subsidy, and we're not receiving the same benefit. And that's what really concerns me. I see the findings, and I see the recommendations on page 11. I agree with that, and hopefully we can get back into that realm. But right now, I don't see where any of this benefits the taxpayers of South County, especially in my district of Willows, and that's what really concerns me. It doesn't surprise me that that's what we're doing, but I do believe that South County should have the same priority as the North County. Our seniors, our people in need of ambulance care should have the same priorities, and the numbers say we're not. So I'll leave it at that for right now.
How about our folks from Orland?
Good afternoon. My first question for you is your mention about the Colusa AMR, that they have contracted with AMR. Was that put out on an FRP?
Yes.
Okay. Do you know how much Colusa is paying for AMR to provide their ambulance services? What's the subsidy?
I do not.
$2 million a year to have $2 million a year to have a private company come in and service your area for ambulance. And what are we currently collectively between Orland and Willows? Anybody done the math? Or Orland and
It's based upon the recent change. Sorry, and just to introduce, my name is John Pullen. I'm the regional executive director of the SSV EMS agency. So with the recent change, we're currently the county and the city of Orland are currently subsidizing Westside $14,000 a month for the 12-hour ambulance, and $25,000 a month, $22,000 a month for the 24-hour. So
about
40,000 ish. Yeah.
Okay, I'm terrible with the math. Last time I did that, it was pretty embarrassing.
So that's
What did
half a
that
million
happen?
a year.
About how much?
About $500,000 a year.
$500,000 a year. So do we really want to go from spending $500,000 a year for a locally based ambulance service? And the next thing that I noticed when I look on page 8, when I look at the response times that we have out of 14 months, West Side Ambulance provided compliance with the response times in 12 months out of 14. Willows Enlow was compliant 1, 2, 3, 4, 5, 7. 1, 2, 3, 4, 6 out of 14. So
Yeah, and I think the supervisor did a good job of highlighting why that is because that extra 12-hour ambulance is actually based out of the Orland area. So they basically have more coverage. And what happened is when Glenn Medical Center closed, every single transport that Enlow does now has to go either to Colusa or to Enlow, which takes them out of service much longer than transporting from Orland to the other area. And then for the supervisor, and I don't mean to interrupt you, but just to clarify, we identified, as was in this thing, an issue with moving that 12-hour ambulance. So we did a lot of work. And so for the month of March, both areas were exactly the same at 85% compliant. And for the month of April, Orland was 96% and Willows was 91%. So it seems to have addressed those issues that you brought up. We had believed that was occurring in the past, but it wasn't. And specifically, when you look at the month of February at the 57%, almost all of those calls were when the 12-hour unit was not on duty. So there was no ability to move that unit up. It just happened to be that those were late at night. And unfortunately, with the Willows ambulance having to transport all the way to Chico or to Colusa, that ambulance, there's just no backup coverage there. So ultimately, generally in a rural EMS system, you're just like Colusa, you're paying for the backup and the availability of the ambulance. The county of Colusa only has about, I wouldn't say quite half, but about maybe 60% of the call volume of Glen here, but they have two still full 24-hour ambulances. But again, the revenue is not there, so someone has to pay for it. So that's why they're using the sales tax to provide that availability and all of that. So ultimately, I mean, could you legitimately say there should be 3 24-hour ambulances on in Glenn County to make sure that all of that's covered? Yeah, but again, you have to have the revenue to support that, because a fee for service, as was eloquently described through this, is just not there, even with some of the challenges coming up with the PPGMT and all that. So,
well, my own personal opinion is when you look at where the revenue is currently coming from that's supporting the ambulances, it's the county of Glenn and it's the city of Orland. Correct me if I'm wrong, but I don't believe Willows is participating in that.
that is my understanding, but I'm not going to speak for those entities.
I'm questioning across the aisle. Is that correct?
You are correct.
Willows is not currently assisting with that. So if Willows jumped in there and Willows said, okay, we're going to help subsidize the second half of the 12-hour ambulance. So we had a single service provider that was 2 12-hour ambulances, and we corrected the inequities that apparently exist as far as where those ambulances are being staged, so that Willows gets the kind of coverage that Orland apparently is currently getting. I believe that could go a long way to solving the problem without putting it out to how many $1 million is it costing the county in Colusa? Okay, it's a whole lot more than we're paying now. So I'm not sure what's making sense here.
Yeah, I think, and John Poland can correct me on this, these are apples and oranges comparisons. Colusa's a lot more land, a lot fewer people. And so if we were to, I don't know what their revenue numbers are, what they're bringing in, but because they're charging 2 million in Colusa doesn't mean that AMR would come in and charge 2 million here. The reason we go to a request for proposal process is specifically to everybody have a sharp pencil. And if AMR always came in as the most expensive, they wouldn't be in business. So we know that Enlow would likely be a competitor, Westside would be a competitor, and maybe others would be a competitor. And so I think we would be premature to say that it would be a $2 million cost. We'd have to dig into the Colusa system more, and John knows.
Yeah, and just to clarify, AMR, I mean, they've opened their books up. It's all public information. They're not making any money in Colusa. That's just breaking even, because again, they have similar resources available, but 60% of the call volume, which again decreases the revenue. So that has to be paid for in tax subsidy.
Anyone else from Orland? Willows.
I have one question. In this study, when you talked about the quality of patient care, Was there any statistics that you were able to derive on Enlow transports, West Side transports for patient outcomes when they got to the facility? Do you have any data to show?
Lori, I love where you're going. It's exactly where we want to drive EMS to, and that's what John and Patrick and their team, we want to get to a patient outcome-based process or data set because it's so tough to connect the pre-hospital data to the hospital data. We're not typically getting that outcome data coming back around. So currently what our focus is in what we call patient processes. So I mentioned earlier about 10 minutes on scene for somebody who's having a stroke or a heart attack because we want to get them to the hospital where they can start reversing that situation with the cath lab, thrombolytics, things like that. Making sure we're doing good pain management, making sure we're getting people's glucose levels, the processes that we know impact downstream. Recognizing sepsis for those that are here in the medical field. By identifying sepsis in the field, it cuts an hour off of the activation within the hospital. And these are the processes that we're all focused on, John and Patrick and their team, to provide better care. Eventually, we would love to be at a point where when I come into my shift tomorrow, I get to see the dispositions of all my cases and who went to the cath lab and got their heart valves opened up and everything else. And was it really a heart attack? Was it not? Things like that. So I love where you're going and I want us to get there. Not there today.
So just in the analysis, there's no way to weigh what fire departments might be to have better outcomes for the patient care.
So excellent question for the first responders. There are many more opportunities than there used to be for EMTs to really affect care. Upwards of 5-8 years ago, EMTs were not couldn't check people's glucose, couldn't give them an aspirin if they're having a heart attack, couldn't give Narcan for somebody on an overdose, couldn't do what's called CPAP, or basically a breathing apparatus to help somebody, couldn't do advanced airways to keep somebody's airway open. All of these things have moved from the paramedic level to the EMT level in the last 10 years. And this county has been a good adopter of those advanced practices. And epinephrine, another one. So if somebody's having allergic reaction, now we don't have to wait for the ambulance to get there because your local fire departments have those opportunities now available to them. So we look to maximize at the first responder level all of that care and for the truly critical patients. We have to balance the load of the first response to the benefit it provides. So for example, if somebody's at a skilled nursing facility and there's a transport because somebody's lab values are off from labs that were drawn 2 days ago, probably don't need the fire department to leave what they're doing, especially if they're volunteers, to leave their jobs for somebody that's medically stable and just needs a ride to the hospital. And so that's where we always have to balance who goes on first response versus how much we're taxing our volunteers and our career staff and making sure they're available for the heart attack, for the fire, for the traffic collision. So it's a balance.
And if I could just add, the data is not reflected in this study, but in November of 2025, we actually approved Willows Fire Department to be an ALS first response entity. So again, the data wasn't really captured in this because we had already kind of started through that process. And so as Bill stated, it's very difficult at this time to kind of correlate that, end all patient care other than the specialty patients like the heart attack, stroke, and trauma patients. We're working with the state on a pilot project to start working on that, what's called health information exchange. So we get that outcome data to prove that, yes, what we did in the pre-hospital setting was great. We know anecdotally that obviously what EMS does in the pre-hospital setting is, provides, life-saving care to patients. And we actually have specific examples of that, but kind of an overarching thing when you look at this data, it's super difficult to kind of ferret that out at this point. It's coming. It's not quite there yet. So.
Hans.
Yeah, thank you. Yeah, first off, thank you for very clear, concise, informative, interesting information. It's a great background. It's definitely information is well needed starting point. So good job. Did a good job with the report. Self-explanatory. Understood everything. And before I make any further comments, just like to thank all of the medics in Low, West Side, standings they provide. Day in and day out, 24 hours a day. Comments I'm going to say next have nothing to do with them. Fantastic job. Concerning to me were the financial identified in the report. West Side conflicting some irregularities in the financial concerning that because there is subsidy from the city of county taxpayer. That does concern me. So good information again. The business models side and in Low were stark in my mind, just looking into the information that was produced. So thank you for that. Clearly, I'd like to see more accuracy, transparency, but Willows does not currently participate in subsidy. And speaking, Plain County resident, not just as a member of the Willows City. So those are my concerns. Those are definitely. But Medi-Cal reimbursement is horrible. It's across the board for Medi-Cal providers. I know what I talk about. Yeah. And then farming and law enforcement. The last 20 plus years of my law enforcement career, after I left the sheriff's office, state of California, Department of Healthcare Services Investigation, where I ultimately became investigation. So working the criminal side of Medi-Cal, I know a lot about it. What I did not know, court came. GMT, I just did not know. But so my clarification question on the Medi-Cal reimbursement, GMT side. On your report, roughly the single provider, single government type provider, roughly 200K, 206,000 profit, roughly approximately. Are those into the current EMT reimbursement rates or the projected reimbursement rates to be at 400? So in other words, is it the $1,500 or the 450?
Great question. So the 220 number you see is based on if there'd been a public provider in 2025. The pro forma, which is labeled next steps for 2026, shows about, I think, 130, 140 based on a slight decline in transports. This report was produced before the announcement 2 weeks ago. So we would have to go back, look at the Medi-Cal, the number of Medi-Cal transports, and to deduct somewhere in the neighborhood of $900 to $1,000 per Medi-Cal transport to then figure out what the new budget would look like. And we don't know when that will we know it's written to kick in 27, 28, but will it get suspended and delayed for a period of time, or will the number come in higher? So we can kind of do a best case, worst case scenario on that. And let you know if it does go into effect immediately as planned, what that difference would be.
Yeah, interesting. Because we don't have a hospital here any longer because of Medi-Cal reimbursement. All it, it happened. The federal government playing their little mileage. So, trust the federal government with this type of thing about as far as I can control. Really.
This same revenue solution that the pre-hospital care is using is what the public hospitals have used for years, for decades, to be cost effective. What happened was that money went away and came back in the rural transformation grants that you may have read about at the federal level. So the money got pulled back and said, oh, we're going to give back to you in this other way. And unfortunately, what's happened is that doesn't mean the same amount of money is coming back to the rural hospitals. So we're seeing Glenn County is, I'm sure you're aware, is not the only county hospital that's closing. It's unfortunate. It's very difficult.
But that's off topic.
Yeah.
It is all related, complicated stuff with this, all this Medi-Cal review. So, and like I say, it's great information, somewhere to start, but got to keep in mind down the road, public provider, are those reimbursements going to be there? Yeah, right. Yeah, first of all, really, those are my comments. Go ahead. Thank you for a good job. Go ahead.
Rick, if I could.
Mr. Yoder.
Yeah, thank you. Just to kind of address Terry's Orland mayor, when she talked about Calusa and they're paying the $2 million. But if we look at the size, and we look at the population, Calusa sits at about 21,000. We sit at about 29,000. That's the size of Orland. So that's where the extra dollars would come into effect. Is that the whole nother city that sits within ours versus theirs. And so when you take that $2 million, I think you got to weigh the population and actually where that population sits, because it is drewn out more in, we have 29,000 family. So I think that needs to be taken into consideration. Just kind of clarify.
Okay. I'm going to reserve comments because, to be honest with you, I'm not into the medical services business. And when I look at all of the acronyms and various reimbursements and the 15 different recommendations the report has, I really haven't had a chance to really digest the merit of each and every one of them, because there's a lot to be there. This has been helpful for me to understand. I look forward to more time and input going forward. We have. Go ahead, Mr. Harmon.
Yeah, I just wanted to bring up, when we first started this program of adding the extra 12-hour ambulance, we were trying to figure out, where it would best be placed and which agency to go with. And we ultimately ended up going with Westside due to the higher call volume up on the north portion of the county. But we also have to remember that we have Enloe that provides the service down in the south part. They were very good partners. They didn't complain. They didn't say, hey, wait, you're giving a subsidy for an extra 12-hour, because we were adding services. Well, since then, now the city of Orland is paying for the 24-hour subsidy to the North County ambulance. Enloe was in the hole about $100,000 a year over year, before we added the 12-hour ambulance. Now that the hospital is gone, they're not having all the interfacility transfers. Their loss each year is upwards of around $300,000. And if we don't look at the county as a whole in trying to solve this problem, I mean, Enloe has been a great partner and eating it, like the gentleman said, they have the hospital that can kind of help absorb. But I'm not speaking for Enloe, but I think that number is so high that there may come a point where they just say, you know what, without a subsidy, we're going to step aside. And then now we only have 1.5 ambulances in the county. So I think that definitely needs to be our big picture. And that's why I wholeheartedly agree with the recommendations of having the one provider, whether we end up going the GEMT route and contracting, whatever, which I think would be beneficial because there's money on the table there. We're stewards of our constituents' tax dollars, and we need to try and get the best bang for our buck. So I just wanted to add that as another part of the picture.
Well, to me, the most worrisome thing would be what the government offers today isn't going to be what the government offers tomorrow. And we can put together models based on what they offer today. Might be able to run 2 or 3, 4, 5 years comfortably until they change the rules again. As soon as we figure out how to operate within their system, they say it's time to change the rules because they figured out what we're doing in the system.
We've been here before. I mean, we have. when Chief Peabody was here. We were in the same position. We didn't have, Enlow wasn't even here. And we had to look at Calusa, and we brought Calusa up, I believe, Doc. Is that what we did? Do you remember when we were way back then, dating myself, when Chief Peabody was here, and we had an ambulance committee, and we tried to figure out how best serve our different entities, our different population, and we got support basically from the Calusa area to bring up and stage when Enlow had to leave, or whenever the provider that we had at the time left the county, then Calusa would come up and they'd sit at the county line for us, and then that way we had coverage. And that was, let's just say 10, 15 years ago, right, Gary? And
just
so
over 5 years.
5, 10 years. So we were in that position, and we're in this position again. How best do we serve our populations and give them the best scenario that we possibly can for survival, is what it amounts to. We don't have a hospital currently operating in the county, so we have these different dynamics that we didn't have when. And I, as the chair had said, is it a single provider, not having duplication of services, administrative services, that drops our costs down, and we are the stewards of our finances for our taxpayers. I would think that you should look in that arena. How are we going to do it more? Yeah, Willows hadn't anticipated. I think that's a good reason. I think it's a good call based on these numbers. But I think Willows area got the service that it would probably. Keep not doing it. Service adequate.
Vice Mayor Thomas. I have a question for, I guess this would be for staff, Chief Monk, Chief Cheney, or Dr. Garrison. So we have a report, we have our recommendations. Is there anything that you need of us, or out of these recommendations, what can we achieve immediately, and what support do you need in order for us to serve our constituents?
I think I can answer. County, cities have two decisions. Do we subsidize or do we not? County bears the burden of, do we go to a one service per? That's strictly our responsibility. Am I right, John? Okay. The county is the one. Yeah. So the cities would only say, okay, we want to subsidize. At what percentages? County, ultimately county make those decisions. How do we take input? But it solely relies on us.
All right, so then how soon can we get going?
Well, that's the $1 million question. I think when we get back to our individual, because right now it's just a presentation. Once we get back to our individual entity, that's something that they would have to, county council would have to discuss and make that. The county would have to, do we want to go with county provider? Do we want to go with two? SSV, I believe, has to notice the exclusiveness of the county that we're going to go out. We're not going to go out, and that process has to. Not going to be a quick process. That process has to.
It might be helpful for this group to understand kind of where we currently stand in Glenn County as far as contracting perspective. So the county's kind of divided in half. County Road, I think it's 33, is the anything north is West Side's area, anything south is Enlow's area. The West Side zone north of County Road 33 is currently an exclusive operating area agreement. However, It was established through the grandfathering provisions of current statute. In addition to that, there's actually language in their agreement that if the county were to direct us, we could actually cancel that grandfathering EOA if the county decided to go a different direction with an appropriate notice and all of that. Enloe Medical Center in the Willows area is what was called in a non-exclusive, as was one of the options that Bill mentioned. So Enloe also has a contract with us, but it's a non-exclusive contract and it has some similar cancellation language in there. It's like 120 days or whatever. So anyways, there is some contractual stuff that needs to be considered, but it's not a roadblock or a significant, issue. Again, depending on what the county would direct us to kind of how to move forward with that. So, and again, we can answer any additional questions either offline or that anyone has.
Any final comments from our fire departments or Harrison? Other comment. We'll take that one first.
My name's Jenny Humphreys. I'm the EMS director at Enloe, the chief flight nurse. And I just wanted to provide a couple of pieces of clarification. Supervisor Yoder, 1998 is when we started putting an ambulance in Willows and Colusa. And why the move up and cover worked is we were moving our own resources. So when we had 2 ambulances in Colusa County at that time. And so when Willows would leave on a transfer, leave on an extended, transport, we moved our own units up. Now I think currently the contract in Colusa is for mutual aid, not move up and cover, right? So AMR doesn't have a responsibility to move up and cover at the county line. Right, coming down. Right, but from the south part, Colusa's contract now is a little different. And before we were just moving our own resources, between county. I did
dating my gray hair. Just saying.
And then a little bit, I just wanted to comment a little bit on the perceived revenue associated with having ambulance service. And there is obviously dependent upon patients revenue that comes with outpatient and inpatient visits. However, it's important to remember that a payer mix is a payer mix. And in Butte and Glenn County, Colusa County, Tehama County, it's very unfavorable as compared to other places in the state. And another thing, a caveat about that is in Butte County, obviously we have Butte County EMS and we continue to choose to leave Willows out here. But those patients would come to Enloe regardless of the provider. Wouldn't have to be us for the hospital to realize that perceived revenue, right? And so really, I think what that highlights is current state. That's a choice for us to support the communities, both in Butte and Glenn counties, because those patients would end up largely at Enloe, regardless of whether it was a Willows ambulance or a Butte County EMS ambulance that was completing those transports. So that really remains constant. And it's, mine and our senior team's opinion, and still is, that the support of the community is why we bid on Butte County and why we're here in Willows still. So I just wanted to offer that bit, that the benefit to Enloe as the health system remains really regardless of provider. And so it is very much a choice, at this point.
May I ask a quick question? So if it were to go to a single provider west side, if it really is someone up in the hills that really needs an air transport, will you, Enloe, continue to send your helicopter out to pick them up?
Without a doubt.
It's not like it was brought up
west side all the time with our helicopter.
That, we need to have Enloe because they have the air transport, but we would call in the air transport even though you're not the
you're making
provider.
The decision. The ground and the air ambulance, it's not that you have to have one to get the other. Right. Okay. So there's very robust policy in place through SSV. We have coordination centers for the aircraft. And so for us on the flight crew, which I am one of them and I can speak to it, we see everyone from Dignity to West Side to our own crews. The ground provider in the transaction or the call is irrelevant to the use of the aircraft.
Right.
And while we do own 2 aircraft, we operate one at any one time.
And just to further clarify that, in addition to their helicopter that's based out of Chico, there's, as was mentioned, Reach, which is a AMR or GMR provider, has a helicopter in Williams. And then their PHI has a helicopter in Red Bluff as well. As you can imagine, once a helicopter goes en route, it's much quicker to get to an incident because they can go line of sight instead of following a road. So really all 3 of those helicopters can service Glenn County, readily available. And really, again, it doesn't matter who the provider is. The helicopters are going to respond if they're the closest resource. We have a robust system. It's really provider non-specific. It doesn't matter who the provider is. You're always going to get the closest air ambulance resource, and that's not going to change regardless of if it changes providers or anything like that. Again, to clarify that conversation about the helicopters, especially in the rural areas, we are completely supportive of that, but we want to make sure that we're matching the resource to the need. Because I can just tell you publicly, and Jenny can back me up, a helicopter bill is infinitely more expensive than a ground ambulance bill. So if you don't need a helicopter and ground ambulance is appropriate based upon response time, transport time, patient condition, that's always going to be the preference. But we need to have those resources available for those patients that need that resource and are critical and need that quicker transport to the hospital. But the default, and we've kind of been working with our helicopter providers and our ground providers for years, the default shouldn't be, oh, well, we'll just send a helicopter to all those calls in this particular area. It needs to be the appropriate patient, because it's not fair clinically or for the patient or for insurance or whatever. We all collectively pay insurance if it ends up being more. And there's some subscription programs that help offset that as well. But, so we monitor that almost ongoing consistently to make sure that those are used appropriately. And there's not a lot of helicopter utilization in this county, but it's done appropriately. There's probably, maybe a couple a month. But again, they're all appropriate, and we don't see an incident other than if weather prevents them from responding where they should be responding and they're not. So we believe that it's pretty well, spaced out and it is utilizing appropriately at this point. But yeah, to answer your question before I went on the tirade, it doesn't matter. A change in ground providers is not going to affect aircraft at all. It has zero effect on that.
That's very good. So, thank you very much. May I finish my little thought? I agree with you. I think there's a lot in here, and I actually spent a lot of time reading it before we got here, but it was wonderful having the clarification and the points that you were able to bring forward concerning the recommendations that are in here. Seems like there's a lot to kind of chew on here. It looks like the number one issue I see is more administrative than anything, that West Side's numbers didn't match. We've seen this before in other venues. The information, if you can't rely on it, how do you know for sure? So we need to dig deeper into the information from West Side and understand exactly what their numbers are and what they mean, without making decisions prior to that. But as you were saying, we have two very important decisions to make. Number one is the health of our constituency, the people that we are here to protect at all costs. And so if response times will affect even one life being saved, we need to consider that. And I am a person whose husband had 2 heart attacks, and I can tell you he would not have survived the second one if it hadn't been a 5-minute response time from the ambulance. And the second thing is, of course, the taxpayer dollars. We are responsible for the taxpayer dollars and explaining what we're spending it on and the reasoning behind why we're spending it there. And when we look at the potential cost, especially if we lose this kind of ollie auction free we've got right now, that's going to go down to $400 soon, it sounds like, making decisions based on variables that may not be consistent is a little hasty on our part. And we probably need to get a little further along that decision-making process, but definitely making a decision that could potentially end up costing us millions, as opposed to what the current services that are literally almost every month meeting the time that they should be meeting to respond. We're back to what I said earlier. If we were spending the money wisely and everybody's kicking in to help pay for it, 2 ambulances of our very own, run by the ambulance company that's been here, 50, 75 years? I'm not even sure. If we've got administrative problems, let's fix it. Let's have a meeting. Let's all of us get together, or our own cities get together, have further discussions, and then have another longer discussions with the county. And I really appreciate what you were saying about the population. But how big is Colusa compared, and what kind of area are we looking as compared to Glenn County? It's not only the number of people, it's the size. How far do they have to go
Similar.
to reach? Is it
Similar.
similar?
Very similar.
Okay. Okay. So maybe that might be left less if we put out an FRP, but I'd say before we do that, let's see if we can fix the problems we currently are facing. The fact that we could go through our fire departments for less expensive medical supplies, great idea. Maybe the fire departments participate in the operation to some degree so that there's a better understanding and hand holding. You know, maybe they need some extra help at West Side. I'm not sure how deep we can go, maybe not tonight, but there's a lot more to be considered before we make a decision. Thank you. And that's my last comment.
Vance?
I can't let the meeting close without publicly thanking Enlo for not leaving us high and dry and providing outstanding here in Southern Glen. Much appreciated. I think I can speak for probably everybody in this room safely. Thank you very much for helping us out and for you took it over. There was formerly West Side Ambulance, formerly covered the entire county. Yes, until one tragic evening in a Wednesday Route 32 that some of us in, and then that's when it stopped and the last ambulance came in, another firm came in. And it was always about the Medi, right? The reimbursement, right? You know, running ambulances is not profitable in a rural area. It just isn't. It's speaking of the choir here. And as we've understood from the report tonight. But anyway, just thank you for always being, for you and your team providing stand. Much appreciated. Go ahead, Rick. Thanks.
Back to Kenny.
I guess I'd just like to say this is probably the biggest topic that this group will ever have to decide on, because there is nothing more important than public safety at the end of the day. And we're literally sitting here. There's lots of numbers. There's lots of information to go over. But at the end of the day, it's all about the public safety and getting people transported and taking care of people. And I think there's a ton of information to go over here. And I think there's lots of ways to get there. And we should probably spend time trying to find that best path, because there's conclusions, but there's not a roadmap to get to those conclusions. And I think it's going to take this group and a very concerted effort by this group to try to figure out what is the best path to actually get to the goal. And I know we have the ad hoc committee, and I would suggest referring it back to ad hoc so that as a smaller group, you know, that some ideas and some thoughts can be floated out to the bigger bodies so that each, you know, Willows, Orland County can all get that information back and make some very informed decisions. Because at the end of the day, I personally, for me, there is no bigger decision that's going to be made by a group in Glenn County as to the public safety and getting people transported to hospitals. And I think the answer's out there. It's going to, but take all of us. I mean, it's going to take the fire departments. It's going to take the electeds. It's going to take EMS. You know, it's going to take everybody together, because it's not a simple solution and it's a very expensive problem, which has been brought up many times tonight. And so trying to figure out how do you get the best service for the citizens and still be able to afford it. I mean, it's a terrible thing to have to actually sit here and say that those are our choices, but in reality, that's our choices. And I think all rural counties are struggling with this. And so I would just have everybody that has the information go over it thoroughly, because I know some people have just seen it recently, and refer back to ad hoc and let some of those meetings take place and see what we can vet out, you know, as far as a good path forward, you know, for a sustainable future. So that's all I got.
Doctor?
You know, I just would like to thank everybody for being here. This is wonderful that we've got so many different people who are here. So grateful that we have elected officials who care about this. And I would echo what Chief Cheney said. This is an extremely important issue. And I think that it's probably going to take a little bit of some outside the box thinking think it's going to take a lot of concerted effort by a lot of people to make this happen. I think that's what we got to do. Thank you. Thank you for being here.
Thank you. Anything else?
I agree with both Dr. Garrison and Chief Cheney. I think that there's a lot here to go over. I think that the three of our roles in this project was to find someone to do the study, give some local insight to the way the system works, to help them with some of that information, and then bring that study back to the three of you guys to go over it and start a path forward. I agree with Chief Cheney that that venue would probably be the ad hoc and start fleshing some of this stuff out to get a next step. I'd like to thank everybody who worked on this and worked on getting all the data together and met with the consultants. And thank you to both Westside and Inlow.
Thank you. So I guess the recommendation from what we've heard here.
I'd have to ask, because it is just a presentation, Scott, is there cannot be a decision made from this body right now.
No, there's no action.
Right. So it
But we
would
can
have
give
to come
direction
back
back
to us.
to, we can give direction.
Yeah, I believe Orland already has a couple of members. We have a couple of members, I think. Oh, you
Yeah,
guys do?
member.
Okay.
I think. Heard back. That I would like to say thank you to everyone who showed up. It is important decisions. Appreciate the presentators, centers, I should say, tongue-tied, but I think we're on a mission. We have to keep on that path. So with that, well, one other housekeeping item, Councilmember Matt Busby did arrive at 5:33. That I will adjourn the meeting at 7:07.